Okay, we're going to switch gears a little bit and we're going to talk about potassium. Potassium is another extremely important electrolyte that we see in our body and does a lot of things to help us and maintain things. So, potassium is a positive ion, a cation. It's going to be in your intracellular fluid, so it's going to be inside your cell, where sodium is the major one outside your cell. So, potassium levels are 3.5 to 4.5. That is a pretty narrow range, and it's really important that your patient stay within that range. So the main thing that I want you to know, this is a heart electrolyte. I know it says it does all this other stuff too, but the main thing that your potassium does is heart related. So it pumps the heart. If our potassium levels get too low, if our potassium levels get too high, we can get into what we call fatal cardiac arrhythmias. So that can actually cause the patient to go into cardiac arrest and can cause lots of bad things to happen. So it plays a vital role in the way that our bodies work. So that's the main thing I really want you to know. It does the cardiac function and it makes our hearts pump, okay? And it's imperative that we correct a hypo or a hyperkalemia. So we're going to talk about a low one first. So let's talk about a hypokalemia. This is going to be a potassium level that's lower than 3.5. So how do we get a low one? Well, a lot of times potassium leaves the body because of fluids. So sometimes it can leave through the urine. So those guys in there that are directing our traffic, we have these little guys in our kidneys that are kind of directing the traffic down there. Sometimes they get overwhelmed. Sometimes they don't catch things and they let too much potassium go out. And a lot of times that's because of our diuretics, our Lasix and certain things. It can be through vomiting, gastric suctioning, diarrhea, anything like that. Steroids. So if you have a patient that is on steroids for whatever reason, maybe they're on steroids for cancer, maybe they're on steroids for inflammation someplace, arthritis, anything like that, that can also cause that level to go down. Hyperaldosteronism. It's not something we're really going to talk about. Aldosterone helps regulate the fluid balance. And if we get too much aldosterone, that can cause us to pee too much, and then that can cause a loss of that sodium. Patients that are receiving TPN. TPN is what we call total parenteral nutrition. So this is when somebody cannot take oral fluids or food. We give it to them through a central line or a PICC line in the arm. And those fluids are usually packed full of a lot of stuff. And it's very common for your patients to get hypokalemia with these sometimes. So those are some of the causes of it. And so this potassium is one of the electrolytes that is really important there. Okay, so what are you going to see? So when you think about your vital signs, some of the things that you're going to see is weak, really irregular pulses, because we said it regulates the heart. So we know if it gets too low, it's not going to function. It's not going to make this, the heart isn't going to work right. They're going to get hypotension, orthostatic hypotension, and then we worry about that respiratory depression. So that's the big things. Now, I'm not really going to talk a lot about all this because it's important, but it's the heart is what I want you to know about potassium. So you're going to look at that EKG. So I know none of you know how to read EKGs yet, but you're going to start seeing something called premature ventricular contractions. It's where the ventricles of the heart are going to fire before they're supposed to fire, okay? And sometimes that's just because the heart is irritable, and the heart gets very angry when their potassium is not like it should be. So when that potassium gets low, the heart's like, I really don't like this, so I'm going to do some funky stuff so you're going to fix it. So it does those kind of things. And so sometimes we will see like a flat little T wave. So you get the P, Q, R, S, and then that little T at the end. So we get that flat T wave. And then sometimes it does cause like nausea, vomiting, things like that. But mainly it's going to be your heart function and your EKG things that you're going to see with your potassium. So that's going to be what you're going to see. So what are you going to do about that? So you're going to have to treat why do they have the low potassium. So that's what sometimes we don't always do in the hospital, is when somebody has a low potassium, we treat the potassium, but we don't treat the underlying cause. Yeah, we're going to get their potassium level up, and that's fine, but then 3 days later, the potassium is going to be low again. So we have to treat what the cause of the low potassium is. Once we treat the cause, the potassium should stay consistent after that. So we're going to find out what is going on inside that patient to cause that potassium to be low. Now, the one thing we're going to have to do is we're going to have to give them potassium. So in the hospital, a lot of your patients are going to be on a protocol. It's called a potassium magnesium protocol. So if their potassium comes back less than a certain amount, you will either give them oral replacement of potassium or you will give them IV replacement of potassium. Just depends on how low and whether the patient can swallow those great big old potassium pills. So we're going to have to replace that potassium. So things that we can do is give them potassium through diet. So if it's kind of low but it's not really low enough that we're wanting to do anything about it, we can go ahead and have them change their diet. So things that are high in potassium: bananas, potatoes. Potatoes are high in potassium. Avocado, dried fruit, cantaloupe, all those are high in potassium. We can give them oral potassium supplements. Now, if oral doesn't do the trick or their potassium's too low, we're going to have to give them IV. The biggest thing about this is never, ever, 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 ever give potassium through a potassium bolus, which means that we are never going to give them an IV push of potassium, because that is actually how we euthanize animals, and that is how they euthanize humans through the death penalty. They give them a massive dose of potassium and it immediately shuts the heart down. So that's not good. So we never, ever, ever want to give it as a bolus. We usually we will give potassium, we'll put it in a big old bag, and we give it over a very slow amount of time, and we watch them. It is also very irritating to the veins and does sting a lot when you put it in. We're going to watch that urinary output. We're going to watch for those respirations, because we don't want those respirations to get too low. We're going to have them on some kind of cardiac monitor so we can watch that irritability of the heart and monitor how their level of consciousness is. So that's kind of what we're going to do for our low potassium. Now, high potassium. High potassium is not as common as low. Okay, so this is blood levels that are greater than 5.0. Now, you heard me say a minute ago, we never give potassium IV push, correct? Because it shuts the heart down. So we don't want someone's potassium level to get really high, because what could happen? It could shut their heart down. So we don't want that to happen either. So we're going to have to monitor that. Now, the reason somebody would get high potassium, one is they've taken too much potassium. Maybe you've had a little old lady in there that came in and we had been giving her potassium, and the doctor said, I want you to take potassium for 3 days and then quit. And maybe she's misunderstood and thought she was supposed to take 5 pills for the next 3 days. She can get an overdose of that potassium. Typically, if your kidneys are functioning and your body's functioning normally, we don't see an elevated potassium because your body will take care of it. But it can happen if it's a quick kind of thing. So other causes is renal failure. So renal failure is another thing that can actually cause this. So think about it. If we lose our potassium, because remember, those people in there are directing the traffic of the sodium, potassium, magnesium, all this stuff. Say, okay, you go on through, you need to get out. Oh, I'm going to keep you, I'm going to pull you back through, and put that sodium back in because our sodium's kind of low. Or I'm going to increase your potassium again. Well, what happens is if the kidneys can't get rid of that potassium's just going to keep getting up and up and up. So the little old lady that took way too much potassium, she's also in renal failure. And so now we've just really made her hyperkalemic because, one, she took too many, and two, her kidneys can't get rid of them. So that's 2 big things for her. So again, it's really uncommon for somebody to get hyperkalemia if their kidneys are working and all them guys in there are doing what they're supposed to be doing. But if we do not correct hyperkalemia, these patients can get life-threatening cardiac arrhythmias, and they can go into cardiac arrest. So this is a biggie that we really have to watch. So what are some risk factors? Well, things that can cause this is going to be we've increased their potassium levels. So maybe we've given them too much potassium. A lot of times, sometimes your blood transfusions will have extra potassium in them just because when the cells lyse, remember the potassium is the intercellular electrolyte. Well, if those cells bust, where does that potassium go? It goes out, so the potassium levels get high. So in blood transfusions, sometimes we see that happen. Sometimes we can get extracellular fluid shifts. So sometimes if we get into hypoglycemic, or we can get into like ketoacidosis, burns, trauma, those kinds of things will cause those shifts of that sodium and potassium. Hypertonic states, which we kind of talked about that in sodium. We get that uncontrolled diabetes mellitus. We get into a ketoacidotic state, and it causes that to happen. And then decreased excretion of your potassium, that's just going to be your kidney failure. Somebody who is severely dehydrated, somebody that's on potassium sparing diuretics. So there's certain diuretics. A lot of times your loop diuretics like Lasix. Lasix causes usually a lower potassium because the potassium goes out with the sodium when they pee. But if you're on a potassium sparing diuretic like spironolactone, sometimes that potassium gets saved, but it really needed to go, and so we can get those high levels. So it's kind of important that we need to watch some of that stuff. And then patients that are on ACE inhibitors. So an ACE inhibitor is a medication for blood pressure, and it's very, very common. It's any blood pressure medicine that ends in april, lisinopril, Catepril, any of those ACE inhibitors. They also will cause them to not get rid of their potassium, so they can have an elevated. And then just age. As we get older, the kidneys don't function like they should, so we're going to end up keeping some of our stuff like we shouldn't have done, like we shouldn't be doing, but we end up keeping some of that potassium in there, which causes those higher levels. So as far as nursing care, one of the big things with hyperkalemia is making sure that that patient's on a cardiac monitor. Because if we have a potassium level of 7 and we don't have them on that cardiac monitor, we're not going to know if their heart does something really weird. And there's a good chance that it will, the higher that we get up in that potassium level. So if we get high, we're going to stop the potassium. So we're going to stop those infusions of potassium. We're going to withhold all their oral potassium, and we're going to restrict their potassium in their diet. That means no bananas, no potatoes, no avocados, no cantaloupe, all that kind of stuff. And sometimes if the potassium gets really, really high, sometimes we have to do dialysis. So we will put a trialysis catheter in, and we will do a quick dialysis and pull that potassium off. And then hopefully the person's body can take over at that point. Sometimes the kidneys just get stressed and they can't get that potassium out of there. So we have to physically go in and get that potassium out, and then we can pull it back in. There's also a medication that we can do that can get rid of that. So sometimes what we can do in our patients, and you don't have to be a diabetic to do this, but some of your doctors, if they have a really high potassium level, they will give them IV fluids with some sugar, and they put insulin in it. And you're thinking, well, insulin's for diabetics. No, we can use this in somebody who is not a diabetic. We're going to give them the sugar, but we're going to counteract it with the insulin, because what that combination does, it promotes the movement of that potassium back from the extracellular fluid back into the cell. So, and I'm of that, but that insulin actually forces that potassium back into the cell. And so then our cells can act accordingly, and then our blood levels of that potassium will get back up again. The big thing here is make sure we maintain IV access. We can give something they do it a lot in the ER. If you have a patient that comes in, they have a really high potassium, we can give them K-oxalate, and a lot of times that's an enema. And K-oxalate, you probably heard that term before, that medication, but we can give that, and that will literally pull the potassium out of their body. We can give them diuretics, and that will pull that off as long as their kidney function's okay. So that is your potassium. And potassium is very important. Remember, it is for the heart. It takes care of the heart.